Welcome. Welcome everyone to today's installment of our Black History Month events. My job here is fairly simple to introduce our speaker this evening, who, as Dr. Dunkley told us, is Dr. Karen Flynn. Dr. Flynn is an associate professor in the Department of Gender and Women's Studies in the Department of African American Studies at the University of Illinois at Urbana-Champaign. Dr. Flynn received her PhD in Women's Studies from York University, Toronto, Ontario in 2003. His research interests in migration and travel, Black Canada, health, popular culture, feminist, diasporic and post-colonial studies. Dr. Flynn's book, Moving Beyond Borders, Black Canadian and Caribbean Women in the African Canadian Diaspora, was published by the University of Toronto Press and won the Lavinia L. Dock Award from the American Association of the History of Nursing. Her other publications include Care for Disruption, Privileging Indigenous and Black Women's Standpoints on Care and Healing, published in Gender and History last year. And another of her publications, of the main publications, is White Supremacy and Interdisciplinary Faculty in Schools of Nursing, published in Nursing Outlook, again last year in 2021. Her talk today is titled Caring for Patients, Self and Community, Conversations with Black Healthcare Workers in Toronto. Let's give Dr. Flynn a warm welcome. Over to you, Dr. Flynn.
Thank you. All right, first, I would like to thank the Missouri Black Studies, University of Missouri Black Studies Department, and in particular, my good friend, Dr. Dunkley, as well as Peace Studies and the Sinclair School of Nursing for sponsoring this talk. Thank you to Miss Mary as well, who is helping me with the with the technology, and Dr. Seba, thank you for that introduction. I also want to thank the audience for your presence here. I know it's 6:37 here and 7:30 from my folks who are in Canada and elsewhere. So I know that there's folks here who are actually not from Toronto, but from British Columbia. But I want to thank everyone for showing up, for being here. I recognize that you could be somewhere else, so I am grateful. All right, so I'm going to try and start with a land acknowledgement. So I recognize in Illinois, even though I thought about doing a Canadian one, but I thought against that, that I am on the lands of the Peoria, Kaskaskia, Penishiaka, Weya, Mesquiten, Ottawa, Sauk, Meskwaki, Kickapoo, Potawatomi, Ojibwe, and Chickasaw nations. These lands were the traditional territory of these native nations prior to their forced removal. These lands continue to carry the stories of these nations and their struggles for survival and identity. As a land-grant institution, the University of Illinois has a particular responsibility to acknowledge the peoples of these lands, as well as the histories of dispossession that have allowed for the growth of this institution for the past 150 years. We are also obligated to reflect on and actively address these histories and the role that this university has played in shaping them. This acknowledgement and the centering of Native peoples is a start as we move forward for the next 150 years. And that's from the Native American Studies on our campus. So for the past 2 years, I've been grappling with this idea of a Black Canadian feminist ethic of care. And so I'm truly grateful for this opportunity, even as we continue to deal with the pandemic, to share my research with you, one that is also motivated by an ethic of care. And I'm going to go ahead and share my screen. my PowerPoint. All right. According to Statistics Canada, in 2021, Black female workers were mostly concentrated in the healthcare and social assistance industry, as 33.8% of them had a job in this industry, compared to 11.3% points more than the rest of the employed female population, which stands at 22.5%. Among immigrant women, this gap is even wider, as 37.9% of Black immigrant women worked in the healthcare and social assistance industry, compared with 21.6% of other immigrant women. Given my own research trajectory, I could talk about Canadian immigration, but what I want to do is to bracket that now. And if the audience has any questions, I can address them in the Q&A. This idea of a Black feminist ethic of care, and I want to think about this as an analytical framework, transpired as a result of the following. Narratives of care evoked by family members, co-workers, and others in the media coverage of mainly personal support workers, PSWs, who died from COVID-19 in May and June of 2020 and January 2021. During that time, I conducted interviews with healthcare workers, especially those who occupy the lower echelons of the healthcare hierarchy, and a panel discussion that I witnessed that comprised members of health professionals against racism, HPAR. So to formulate a Black Canadian feminist ethic of care requires drawing on Black African Canadian feminist thought as developed by my friends and colleague, Erica Lawson, Natisha Massaquoi, and Joki Wayne. To speak then to Black women's historical and contemporary reality, a Black Canadian feminist thought takes as its starting point the following, which is not an exhaustive list: immigration and citizenship policies, a gendered and racialized workforce, as well as an official multicultural policy. Also critical to Black Canadian feminist thought are the multiple and varied ways that Black women resist oppression. My own contribution to Black Canadian feminist thought includes how Canada grapples with racism as a nation, which influences how Black healthcare workers are situated within the Canadian healthcare landscape. Finally, Black Canadian feminist ethic of care must be deliberately intersectional. So in the coverage of all the major news outlets regarding the deaths of Arlene Reed, Sharon Roberts, Leonard Rodriguez, and Maureen Ambersley, their race and gender were virtually ignored. The same is true for scholarly articles about PSWs. While there's some acknowledgement that PSWs are disproportionately immigrant women, there's very little analysis of how race, gender, class, and ability and age intersect to shape their experiences. Formulating a Black feminist ethic of care presents a few conceptual and analytical challenges, which are not necessarily mutually exclusive. For PSWs, it requires confronting the reality that their labor is defined as unskilled and menial, which influences public perception of the women and men who do this work. Moreover, making the claim for a Black Canadian feminist ethic of care has the potential to reinforce tropes of Black women healthcare workers as self-sacrificing or as superhuman, a criticism that members of HPAR raised. This is especially worth considering given that I'm making this argument that HPAR's advocacy work indirectly contributes to wellness. With this in mind, I argue that caring is a social construct which is discursively, materially, and ideologically produced. In terms of how an ethic of care is practiced by the healthcare workers under discussion, I use ethic of care without to describe the various forms of advocacy work that is done on behalf of patients and community, and ethic of care within that involves practices that focuses on the self. This presentation is divided into two sections. I begin with the media coverage as a way to memorialize the mostly personal support workers who were casualties of COVID and how they make visible ethic of care within. Given how PSWs are positioned in the larger healthcare hierarchy, I draw on an interview conducted with Gloria Turney, a personal support worker, that further shed light on how ethic of care is actualized. The rest of the presentation focuses on health professionals against racism, who they are, their experiences with gendered racism, the impetus behind the formalization of HPAR, and the way they enact ethic of care without and within. So who are PSWs? PSWs are unregulated healthcare professionals who are instrumental to Ontario's healthcare system. They provide up to 80% of direct care to residents in home community care and the long-term care sector. Initially, PSW's responsibilities were limited to activities necessary for daily living, such as bathing, dressing, toileting, and feeding. Tasks that I want to remind folks were once the purview of nurses. Over time, their role has evolved and PSWs have assumed greater responsibility with respect to patient care. Indigenous and Black feminist scholars have argued that caring is a political act because it disrupts the systems of domination. Media interviews conducted with family, co-workers, and in the case of Maureen Ambersley, families who benefited from her care labor provide concrete examples of ethic of care without, as well as unsettled cherished ideals of the Western nuclear family as reflected in recollections from family members and co-workers. Reed, Rodriguez, Roberts, and Ambersley worked in institutional settings constructed on European norms that is hierarchical, values the mind-body split, and where racialized workers are primarily responsible for menial work. Thus, Reed, Rodriguez, Roberts, and Ambersley humanized their work, placing value on the people they cared for. In doing so, they disrupted normative beliefs about the institution of family by forging emotional relationships with those in their care. They not only cared for, but loved their patients. Originating from cultures where families are not necessarily biological or nuclear, and where elderly people are valued, Audrey Reed, Leonard Rodriguez, Sharon Roberts, and Maureen Ambersley stood in the gap for those confined to long-term care facilities and were often neglected by their own families. As Leonard daughter poignantly reminds us, her father knows the people he cared for better than their own families. Advancing a Black feminist ethic of care then acknowledges that PSW's disproportionate representation in direct essential care is what led to these PSW's deaths. A Black feminist ethic of care then seeks to make visible how PSW's care labor is intricately connected to racial capitalism. Yet when PSWs and other healthcare workers, regardless of where they are situated in the healthcare hierarchy, speak for themselves, they shed light on how they navigate the exigencies of the pandemic. With PSWs and other ancillary healthcare workers, it is important to avoid focusing exclusively on the health marketplace, because to do so would reduce these workers to mere bodies and to mere laborers. Healthcare workers are active agents who make conscious decisions about their work, self-care, and wellness. I use the case of Jamaican-born Gloria Turney, a 50-year-old PSW, to illustrate. Turney was a close friend of Audrey Reed. She too works at 2 long care term facilities, which is not unusual. Given the low wages, PSWs often work at multiple care facilities. At the onset of the pandemic, coupled with Reed's passing, Turney thought about resigning from one of the long-term care facilities, but decided against it. She explained, quote, "I thought, what are you running away from? You could go out in the street and have an accident. For some of my clients, I'm the only person they're used to seeing," unquote. Turney mentioned that she had other options besides resigning. She would have been eligible for the Canadian Emergency Response Benefit, or financial support rather, provided by the Canadian government, as well as employment insurance. But she chose to work instead, stressing emphatically, "It's not for the money. We're not well paid. Definitely not for the money." Turney is active in SEIU Healthcare Union. And to further illustrate that it's not for the money, she says to me, quote, "I sat on a bargaining committee. We got a 33% raise for the next 3 years. This is not a glamorous job. We do it because we are compassionate." Similar to Reed, Rodriguez, Roberts, and Ambersley, Turney's ethic of care without is evident in the investment she had in her clients' welfare. When it appears to her that I might not believe her, she again drives the point home by breaking down her wages and saying again to me, "It's the client, not the wages." She says, "I make $19.13 an hour before taxes. But as a result of the pandemic, PSWs were eligible for another $4, which was temporary pandemic pay from the Ontario government." In this way, she articulates the complicated dimensions of PSW subjectivity as healthcare workers. Turney is fully cognizant of the composition of her union, primarily immigrant women like herself, mostly Latina women and Black Caribbean immigrant women. She acknowledges her wages and the actual nature of the work, saying, "This is not a glamorous job." And despite losing her friend, Audrey, and recognizing the uneven impact of COVID-19, Turney chose to center her patients while continuing her advocacy work through the SEI Healthcare Union. At this point, I want to turn to the conversation that I have with 4 members of HPAR, Leslie, Maria, Helen, and Dorcas. Helen, Maria, and Dorcas are from Kenya and Zimbabwe. Dorcas lived in the US before migrating to Canada. Leslie was born in Canada to Caribbean immigrants rather. Before discussing the formal creation of HPAR and ethic of care work within and without, a discussion of the nurses' work environment is warranted. The members of HPAR currently work at the same hospital and have a total of over 40 years between them. And as I will illustrate shortly, COVID-19 exacerbated longstanding issues of gendered racism at the hospital they worked at. So there's this wonderful scene in Shonda Rhimes' drama, Scandal. And yes, I watched Scandal and watched all 7 seasons, starring Kerry Washington. And there's this scene where Papa Pope, played by Joe Morton, has a conversation with his daughter, Olivia Pope, played by Kerry Washington, after she was outed as the president's mistress. Morton gave this amazing Emmy-winning performance. And if you haven't seen it, I encourage you, you should. The conversation goes something like this. Papa Pope, how many times have I told you you have to be what? To which Olivia replied, twice as good. Papa Pope responded, twice as good as them to get half of what they have. Let's say it again, twice as good as them to get half of what they have. So in whatever iteration, I believe Black women working in predominantly white spaces know Papa's post message to be true, and nursing is no exception. Regardless of their experience and specialty, all the nurses discuss the struggle of navigating a work environment that, compared to their white counterparts, they're often viewed as less competent and skilled. Believing that education is the all-time equalizer, the nurses work to ensure that they have the requisite qualifications, but even then, the cement ceiling remains. Leslie has been at the hospital since 2000. She summarizes her experience as follows, quote, "You have to be great at what you're doing. You have to be number one. And even if you're doing a great job, you weren't recognized for it. I have to give 120% to just look as if you're giving maybe 75%, unquote." Maria started as a PSW only to realize nobody takes you seriously. She completed a diploma, worked as a registered practical nurse, and then went back and completed her RN degree. Maria worked for a bit in medicine, and then she decided to do specialized nursing in the ICU. For Maria, it was a matter of proving herself. She went back and did a master's degree and currently works as a nurse practitioner. For Maria, acquiring knowledge is dividend, where the return is that her colleagues trust her. She states, quote, "It's still a matter of proving to them that I have all this knowledge and that they gain some trust. Then once they gain some trust, they warm up to you. It's only Black people, unfortunately, that I find we have to continuously prove ourselves to them," unquote. Education, expertise, and qualifications rarely translate into leadership position. Leslie explained it this way, quote, "I always felt that I had to fight for a position to be in charge. They would always put people with less seniority than me in charge at times, and it would be frustrating," unquote. All of the aforementioned factors to consistently prove oneself has serious implications for Black nurses' health and well-being. Helen's chilling summary of their workplace and its impact is worth quoting in its entirety. Quote, "I see a lot of people, they don't talk about it. They're so angry amongst us. Those who are not able to vocalize when you approach them, they sound like they're angry. They've been beaten for far too long that they chose that path. I'm not kidding. I've met some Black colleagues outside and you talk to them and you're like, are you the same person I see at work? The work has become a prison. When you walk into that space, you're not free to be yourself. Can you imagine a shift of 12 hours, 4 times or 5 times a week where you have to be role playing? Eventually, you become a prisoner, have mental health issues, physical illness," unquote. It is these issues and more that brought the nurses together informally at first. The group was clearly a respite that speaks to the ethic of care within. In her description of how the group functioned, Maria explained, quote, we can vent, we can talk about our problems, we can talk about everything that you encounter at work and just getting advice from everyone. It was nice to see that we're in the same boat. We have the same issues. They might be different in some ways, but pretty much the same. It all boils down to racism. Even as the nurses understood how white supremacy functioned at their hospital, they were limited to talking among themselves. According to Dorcas, quote, obviously at the time, we didn't complain. You just take it and go along because you dare not complain and lose your job, unquote. The pandemic would change all that. Similar to the US and Britain, COVID-19 exposed the vulnerabilities of Black communities in Canada, bringing into sharp relief and intensifying existing structural inequalities. And as mentioned earlier, Black healthcare workers, especially those in the direct care industry, such as PSWs, have been disproportionately impacted by COVID. Helen recalled 2 interconnected occurrences at Grand River Hospital, which was a straw to break the proverbial camel's back. She recounted, I remember we were on a unit that was just all of a sudden transformed into a COVID unit. Then Black nurses would come in every single day and they're assigned the COVID patients, she states. So regardless of where they worked, whether they worked in long-term care facilities or in hospitals, there was an overrepresentation of Black healthcare workers on COVID units. Helen was also shocked at the disproportionate number of Black COVID patients being admitted to the hospital. She says, we started seeing PSWs coming from the nursing home, colleagues that we work with being admitted to the unit, Black men taxi drivers, and Black women. For Helen and other HPAR members, it was a contradiction in terms of the discourse regarding the demographic being impacted by COVID. For them, it was not only the elderly in long term. Helen admitted to being traumatized by the disproportionate number of Black people she knew that were COVID patients. it was time to act. For Noddings, an ethic of care is demonstrated when people genuinely care about another unjust situation to respond to it by taking corrective action. This is what Helen did. The solution was multi-pronged. First, dismiss the erroneous myth that COVID does not affect Black people. Second, she began to communicating with Black nurses on the unit. She then spoke to Black nurses, explaining to them that, quote, if you have a COVID assignment, it has to rotate. I take the assignment today, somebody takes the assignment tomorrow, unquote. Helen was summoned by the manager, and she relayed the conversation as follows. She's, quote, she's like, I do not like the way you're talking about racism on the unit. I said, well, why don't you like me talking about racism? Oh, it's unpleasant. It's a very uncomfortable conversation. People are not happy with that. I said, that's my plan. I plan to make them uncomfortable because these conversations are not comfortable, unquote. Herein lies Canadian nursing dilemma, and by extension, the Canadian dilemma. Despite being a white settler colony, there continues to be a level of amnesia and denial with respect to Canadian nursing role in perpetuating racism and other forms of oppression in its varied manifestations. As I argue in my book, Moving Beyond Borders, it is difficult for the occupation to grapple with its racist past, much less its racist present, and because it constructs itself on specific gendered ideals, such as caring, which makes it difficult to conclude that nurses who possess such supposedly natural and innate qualities, such as caring, could simultaneously be racist. The response to Helen and her colleagues speaks volumes. According to Helen, they were brought into human resources and were moved to other units. The group attempted to seek assistance from a nursing organization, which will remain nameless, but according to Helen, they were not helpful, even as they could see this injustice taking place. Then, beginning in the 1940s, when Black Canadian young women were prohibited from attending Canadian nursing schools, nursing administrations and organizations were hardly the vanguard of fighting against discrimination in nursing. Then and now, many were able to extend this ethic of care purported to be one of the core values of nursing to Black nurses. Helen cited another incident that confirms how tropes of Black women, to use Dorcas's description as superwomen or super people, influence how they're treated. Helen recalls a conversation with Dorcas when management came in to talk about PPEs. After the meeting, she noticed the white manager went to each and every white nurse and asked them, "Are you okay? Is there anything I can do to support you?" According to Helen, I turned around and I said, quote, "Well, I need support too. Can somebody come and give me some form of consolation? I'm also in this quagmire," unquote. Helen opted to give management the benefit of the doubt, so she asked Molly whether management spoke to her and attempted to console her, to which Molly replied in the negative. At that point, Helen explained, it was a can of worms. COVID just opened a can of worms. It was boiling, it was about to pop. COVID came in at the right time to open it all up. After these incidences, the group began to meet in earnest, and according to Helen, they became their own caregivers. She explained, quote, "We decided to get therapy. We have our own self-therapies," emphasizing that therapy became WhatsApp groups. We went back to the old African adage where as a group, we're stronger together. We came in and we talked amongst each other. We understand that when we talk about racism, to us, it is lived in body and flesh. We can relate to it. To make a bigger impact, they had to move beyond the ethic of care within. HY was born with the objective to advocate, according to Dorcas, for Black employees, but also patients. Whether within or without, aged care advocacy work is intricately linked to health and wellness. Their engagement in ethic of care without, in many ways, embodies expressiveness, emotion, and empathy, elements that Patricia Hill Collins explores in discussing African-American ethics of caring. At this point, I'm going to talk a little bit about HPAR, how they engage in ethic of care without, as it relates to Black patient care. While there is substantive evidence that Black Canadians, especially those from poor and working class, backgrounds are underserved in terms of their healthcare needs, how healthcare providers contributed to this phenomenon needs to be explored more. Women's Health in Women's Hands Community Health Center, the first of its kind in Canada, located in Toronto, was developed for Black and racialized women to address specific issues they were facing, which suggest structural inequalities in Canadian healthcare system that also involves nurses and physicians. HPAR recognizes that it's not enough to focus exclusively on Black employees. Helen asked, if we as nurses are getting challenges in the workplace, what about patients? The nurses have witnessed discriminatory treatment by white staff at Grand River Hospital who discriminate against Black migrant patients. Helen explained that she has personally had a few experiences where Black patients come into the unit and no one assesses them, no one asks the patients questions because the assumption is that they don't speak English. This kind of labeling, Helen points out, quote, leads to decisions being made on behalf of the patients. Once the patients are labeled because of their first language, she points out that decisions are made for them. Quote, that means that your diet will be decided by whoever is admitting you. That means that your care needs will be determined by whoever admits you. I started fighting because I would come in and the person would tell me, oh, this person, I didn't have a lot of history from this person. Did you attempt? No. Why? Because I was told English is their second language. There are also occasions where patients are also their own advocates and no one listens to them. Indeed, HPAR recognizes the vulnerability of patients and take the necessary steps to advocate for them. Other ways that HPAR members practice ethics of care without is ensuring that Black patients are aware of their presence. If one HPAR member is not at work, she'll convey to others we're working to check in on the patient. Helen sometimes goes as far as to provide her personal phone number so patients can call her. Maria was explicit in what I refer as her diversity, equity, and inclusion work with patients. She states, quote, I'm biased, and I think the white folks are the same too. I'm biased towards them. I give them extra care because I know they don't get their care from everybody else. I take my time with them. I give them all the attention. If there's extra stuff I can help them with, I do. I do over. I go over and beyond all the time. I think white people see that. The white nurses see when we do it, but I think they do the same with their white patients as well. I don't see anything wrong with doing that. I give them extra care whenever I can. I find that works. And obviously she's referring to Black patients. The nurses also mentioned that it's not only Black folks they advocate for, but also other racialized patients who are often happy to see them. According to Dorcas, they feel more trusting of them than her white counterparts. Leslie, however, had a different response to the question about Black patient care. She points out that her parents, being one of the few Black settlers in Kitchener-Waterloo, had a networking system that benefited the small community. She explains, quote, I find with my parents, if there's anybody that's in the hospital, they let me know, and I'm that person that will go and visit them, make sure they're okay, unquote. Clearly, there are several ways that HPAR practices ethic of care without, but another example serves as the final illustration. HPAR recognizes there's a disconnect between Black and racialized patients in hospitals, which has dire consequences for the health of the community. Helen noted that in some of the meetings, she recommended that hospital staff, instead of asking the community to come to the hospital, suggest that they go to the community. She says, quote, you don't wait for them to come to the hospital and try to talk to them about their issues, unquote. So at this point, I want to circle back to one of the points I made earlier about developing a Black feminist ethic of care, making the case that HPAR's advocacy is a form of wellness, and how this might reinforce stereotypical tropes of the Black superwoman. So in their advocacy work, HPAR developed a 10-point plan that they're holding their hospital to. They have challenged racist hiring practices and have been instrumental in the hiring of qualified HPAR members in key positions. While there's still much work to be done, and they're doing it with Molly and Leslie in leadership roles, they pointed out that they helped to alleviate some of the pressures faced by Black nurses. So in this conversation, speaking directly to Leslie and Molly, Helen offers the following, quote, "I've seen you guys remedy these situations. I've seen Black nurses who are just getting into the field, coming to you, and you have been so helpful. For me, this is a movement. If we could get a representative all over, we can change. Change is going to happen." HPAR goal is not to settle for one Black nurse in a position of power because they recognize the burden of that responsibility. Instead of one person speaking on behalf of or acting as a representative, one of HPAR goal is to diversify their hospital. Helen's statement then confirms my argument when she says, quote, "We want to see whether we can distribute and get more people in management so we can have more people speaking for us. That's where health and wellness come in." And so at this point, I want to, so this is, I know it's small, but this is the call for action that HPAR developed for their hospital. And I also want to go quickly to their website, because I want you to see just a little bit of the work that they're doing, volunteering at COVID testing center in primarily Black communities. And then they also have t-shirts that you can order as well. So yes. So in conclusion, when I had conversations about wellness and health, we concurred that as Black Canadians, okay, so I don't live in Canada anymore, this was a discussion that is long overdue. Black nurses in particular find that they're in a conundrum. According to Darkus, quote, "Health and wellness has not really been addressed or not too talked about because we're busy doing other things and taking care of others." And for some folks, it's, you know, other people, including aging parents. And she points out that they tend to forget about themselves. What are some of the ways then that HPAR members are practicing wellness or ethic of care within? Mediation, exercise, and taking time off. At the conclusion of our conversation, Les reminded the group that they should celebrate their accomplishments because they're not good at doing that, or focusing on their mental health, which is something that they often forget. After the lockdown, Leslie told the group, quote, "We need to make a date that we can go out and celebrate and have a good time because I think that will help relieve some of the stress," unquote. Outside of their advocacy work, which is critical and necessary, HPAR members are aware that self-care, as Audre Lorde reminds us, is a political act, and they're committed to care not just for the community, patients, but also for the self. Thank you.
Thank you very much, Karen. All right, at this point, we're going to ask the audience if they have any questions. You have two options. You can type the questions in the chat, or you can raise your hand and we'll try to make the technology work for us, and so you can speak your question. As we wait on the responses from the audience, I would like to ask a question. My question, Karen, is about the racial relations between the Black nurses, the Black healthcare workers, and the white patients. Is there, what's that dynamic like? Because sometimes I hear some stories which I find kind of unbelievable, of people denying, rejecting sort of assistance from nurses because of on the grounds of race. So I'm wondering if any of these things, if you see this coming out there, what's that relationship like?
Right. So I actually, I mean, I know that because I know that is happens quite a bit, and in my book, Moving Beyond Borders, it appears to me that the idea of Black hands on white bodies was a huge factor because of the recent migration of Caribbean nurses back when they migrated to Canada. So in the late 40s, 50s, and 60s. I, however, didn't, I know that it still exists, but I didn't ask members of HPAR because I wanted to focus more so on, this idea of wellness and well-being and focus on Black patients. I didn't ask about white people or white patients.
Dr. Thompson, Professor Thompson has a question. Do you know if the Black nurses are treated less than the First Nation nurses in Canada?
I think that there are some parallels between the treatment of Black nurses, Black healthcare workers, and First Nations healthcare workers, Indigenous healthcare workers. In fact, one of the Admire had mentioned this article that was published last year, and in that article we talked about sort of the commonalities between the treatment of Indigenous healthcare workers and Black healthcare workers. So there are definitely some similarities, and as a result of that, myself and my colleagues, we're trying to do much more collaboration around even COVID. Well, I was asked to be on a grant to look at the impact of COVID also on both communities. And so Helen is actually here. So she's sort of the go-to person for HPAR, and she has her hand, so she probably could also speak to this question as well. Hi, Helen.
Oh, am I, can you hear me?
Yes.
I can hear you. I'm so glad you came.
Thank you so much, Karen. I am so, I'm so happy that you really spoke to this and really gave power to HPAR and the conversations that we had. I just did want to talk a little bit about Dave's question about Black nurses and how they are treated right now. It's an ongoing problem. I don't know how many times you would walk into a patient's room and they would totally say they don't want a Black nurse in the 21st century. And sometimes they use certain adjectives. They would say, can you send somebody who speaks English? Which is a form of othering too. Somebody who speaks English, especially if they don't like what you're telling them. I don't know how many times we as Black nurses would go into somebody's room and they ask you to clean the floor. Can you put this garbage here for me? And then when you're done, they're like, oh, can you call me the nurse now? So those in management, like Leslie, somebody would come in and be it a patient, and they would be like, can you call the manager for me? And when you tell them you're the manager, they're like, no, there must be another manager. So there's this belief that a Black person can hold any power, even if it is in a small position, yet you are more qualified than even the manager. You can answer all the questions. In our department, the manager actually, she's not even a nurse, so doesn't have any clue what nursing is. So any nursing questions, instead of being directed to the nurses, they would direct it to the manager, and then the manager would bring it back to us. So it's really, really something we grapple with. But now we've learned how to handle it. We would go in. I call it out. If somebody says they want to speak to somebody, I just tell them that is racism, and it has no place in this space. And I'm going to walk away. If you want me to nurse you, I will come back and we can have a cordial, respectful relationship. So I do that even if it is not me, even if it's somebody else. Once I hear of it, I go in and I address it. And I have talked to management and I told them I am in a good position. I think I can handle this. So a few times it has gotten me into trouble, but they know that when I'm there, I take charge. We take charge and we handle it there and then, because we cannot leave it to management to handle that. Because these nurses go home, they're traumatized. These nurses go home, it plays around in their mind. It makes them feel like lesser beings, especially the young nurses who are hearing this for the first time. So to alleviate that, we go in, we handle it there and then we felt the consequences later on. And then you did talk about Black nurses vis-a-vis the indigenous nurses. I agree with what Karen is saying, but I would like to think that Black nurses, our Black skin precedes us. So, I find like sometimes indigenous, like they do have the same challenges, different challenges, but when we walk into a room, our skin color speaks volumes. It doesn't matter whether you have an accent or you don't have an accent, you are just seen. And so I do believe that we are at the bottom of the barrel. When it comes to discrimination, we are at the bottom of the barrel. So even when we were forming HPER, we did try to even come together with other groups, but they didn't seem to have the same experiences as us. So there was a little bit of a reluctance, because when you talk of management, they are Indian managers. They are, they are there, but there's no one Black nurse in this institution. We look at other institutions, there's none. So I tend to think that, it's uninformed, but we are at the bottom of the barrel. We are at the bottom of the barrel. There's different classes, but we are right at the bottom of it all. And somebody else can help answer these questions better than me. Thank you.
Thank you very much. Somebody else, Lydia is asking about the position of Black men who are working as PSWs and nurses in relation to this, to your Black feminist ethic of care.
Okay, thanks, Lydia. Thanks for being here too. So the Black feminist ethic of care, in the way that I conceptualize it, it is inclusive rather, and it also includes Black men as well. In terms of the interviews I conducted, when I was given numbers rather, or names and the number of names of people who I could contact, I didn't get any numbers relating to, or names rather, I keep saying numbers, names of Black men who are working as PSWs, as personal support workers. And that is not to say that they don't exist, but this is actually an ongoing project. They do exist because obviously with Leonard Rodriguez was somebody who was a PSW. So yes, so my Black feminist ethic of care is not limited to Black healthcare workers. And I want to say that to make that very clear. Great question.
Yeah. And Sean is asking about underpayment of African American, of Black nurses and healthcare workers. In terms of, did you do a comparison in terms of the salary scale? Is it with their white nurses? Is there a difference there, or are there legal standards that establish parity that cannot be made apparent? What's going on in terms of compensation?
Okay, so that's not a question that I asked, but I know that in my conversation with Helen, perhaps Helen, and I don't know if any other HPAR members are here, because this is how you do collaborative work, right? I told them that, I want to make sure that I do justice, but I didn't want to take their work, present it, to take their sort of their, the conversations that we have and present it without their them being present. But overall, just to give you some statistics, with respect to Canadian Black women in Canada in particular, Black women are, and I think it's also similar to the US as well, they're more educated, right? More educated than the general population. And I do believe that there is salary discrepancy. Particularly as Helen pointed out, there's people in leadership positions who are not necessarily nurses, and I'm sure who are also making more money than Black healthcare workers. I mean, I know, well, PSWs, RPNs are underpaid, just without any question. I mean, $19.13 an hour is not a lot of money. And particularly if you live anywhere in Toronto or the outskirts, the greater Toronto area, any of the suburbs, I mean, homes are like $1 million, right? Like so in essence, that they're underpaid. But Helen, I don't know if you want to speak to that situation with your recent position quickly. Your hand's up. Go ahead.
Am I mute? Oh, let me blow my hand. Sorry, that's a generic hand. I did share with Karen a situation where when we are under the union owner, I think there's a little bit of fairness in the sense that they dictate they stipulate what the pay is. But I will give you an example. I really wanted to trial out and see, I'm currently doing research in healthcare leadership and why there are no Black women. And I decided to try to wet my legs, get into leadership and see. So I went into public health and I got the job and they interviewed me well, and and when they told me how much money they were paying me, I looked at them and I said, you're going to pay me less than what I get paid in my current job? And they did ask me, there's an option to negotiate. You can negotiate. You can negotiate. So I went in and I negotiated blindly. I just wanted a penny more. Didn't go in for big bucks. I just wanted a penny more because I didn't know what I was going into. I have no experience. I do not know what leadership is. I don't know what they get paid because those we are not there. So who would mentor me? Nobody. So I went and negotiated. I got $2 more and I was excited. I went to work and then I met this white girl who has less education, less experience. She's only been in nursing for 4 years. We've been 10 more years. I have a master's. I'm doing my PhD. She just barely has a degree and she's managing. And I did talk to her and she told me, oh, I was asking totally something different. And she said, oh, we get paid very well here. She gets paid almost $15 more than I get paid. And I was shocked. So they decide that who gets paid. And then I met somebody who gets paid less than me. So that person who is also in management and is Black is getting paid $20 less than the whites. So there's a big pay discrepancy. So we did decide, abruptly, let's. So that's another fight I started now. I'm only 2 months in the job. So I reached out to the equity and inclusion man and said, there's a problem here. We cannot be doing the same work and being paid $20 less. This is problematic. And it's the 2 Black managers that you have are getting paid the lowest. So if I was there for a long time, I would have said, okay, if it was a long time, I would have dropped out. I would have said that, no, enough, I'm done. I can't do this. But then this is why Black people are not in management. Because the moment you realize that somebody else is making $20 more than you, it's very discouraging. And you're more qualified than them. You bring a lot on board. So really, there's pay inequity too that plays a big role in why Black people just don't want to get into this management position. So it's a big fight that we have to grapple with. Thank you, Karen. You're not overstepping. You're doing an awesome job. Don't feel obligated to go to explain anything. You're doing a good job.
Thank you. I just love Helen. Oh, Dorcas is here too. Okay, Dorcas. Dorcas is not so another HPAR member.
And is asking whether the professional nursing organization in Ontario, the RNAO, is supportive of this work? I see you holding down your head. That's a tough. Is it a tough question?
Well, I'm gonna have the Dorcas and Dorcas respond as well, but I noticed that that last week, I believe that the RNO, the Registered Nursing Association of Ontario, issued what they refer to as a groundbreaking document around dealing with anti-Black racism. They actually had a panel, but at the time I wasn't able to attend, and I'm still really interested in what they are doing. I know that ONA has made the Ontario Nurses Association, which is the union, have made some efforts to address anti-Black racism, having had conversations with them. I think there's an acknowledgement that they haven't addressed this work when they should have. Like they're late. They're very late, and there's an acknowledgement of that. But for me, a lot of it, what I see is, and this is very typical, I believe, of just even the US and Canada, is that there's all these reports. Like there's tons of reports. There's always a report. Somebody's doing a report. Somebody's doing a meeting. There's all these reports. And I'm like, enough with the reports. In 1992, Stephen Lewis, after the so-called Yonge Street, quote unquote, riots, Stephen Lewis drafted a report that was really extensive, that spoke, this is 1992, that spoke to anti-Black racism. So my response to all these nursing organizations is go back, find the report, and build on the report, right? I do think that there's a lot more work to be done, but I also, and part of that is stemmed by the fact that I think Canadians have a real hard time imagining themselves as racist. I think that's part of the issue. And as long as the United States exists, right? As long as United States exists, where they can always say, we're so much better than our neighbors next door, then I think it prevents, us from looking really at anti-Black racism. I think that, with George Floyd, there's been a lot of what appears to be anyway, some work around addressing anti-Black racism, but we'll see. Ask me in 10 years.
Okay. Dorcas. Yes.
Oh, hi, everybody.
Yes.
Thank you, Karen, for that very good talk, and talking about mental health, wellness among healthcare providers. It's very important and very necessary for people, not only healthcare providers, but also other people to hear it. I just wanted to say, just to piggyback on what Helen was saying, is I think there's an essence of fear, is what I see. And I say that because Black people, and particularly Black women, are rising. And they're rising in a way that white people did not expect. And I mean upward mobility that they did not expect to happen so soon. And so from my observation, being in the hospital, I see a lot of fear in white people's eyes. And they almost don't know how to handle the situation. And so there's a big pushback. And one of the things that I remember when we met our CEO as HPAR, I said to him, there's no turning back. If anything, it's just going to get worse if you want to look at it that way from your own perspective. And I don't think this is just unique for Grand River or where we are at. I think this is generally, we are seeing a shift even in the labor force. And one of the things I remember asking when we were invited at the ONA conference is, are people ready for the shift that's coming? And it's coming very soon. How are you going to work with the next person who doesn't look like you, who doesn't talk like you, if you cannot accept it now? And so one of the things that I'm seeing at Grand River is an urgency of trying to shift things, bringing in this diversity and inclusion. And it's not just Grand River, it's across institutions. If you look, public, private, there's that urgency, because there's a realization that it's not going to get far without others, and particularly Black people who've been left behind, and they're learned, they're qualified, they have experience. And so for that essence, that fear is there. I do see it personally, and it's just white people do not know what to do with it currently. And so for me, it's I don't look at it as, but I don't necessarily look at it as, we are at a loss. Actually, we are going to gain. We are gaining, and I don't think there's any. I don't think there's any two way about that. It's just accepting the facts as they are, and we can currently see what's happening in Ottawa with the Freedom Convoy insurrection in January 6th. I don't have to say more than that, but it's just a lot of fear that has come on. White people have woken up and just realized, wow, we were sleeping for a long time when others were awake and working. And now here we are. And not to mention that their numbers have dwindled, and the other, Black people and other minority numbers have grown. And so those are facts that you cannot eliminate, and they're here, and they're just going to continue happening.
All right.
Thank you.
Thank you very much, Dorcas. Yes, I think that one of the big takeaways from this is that the nurses, the professional nursing associations and all different organizations need to start taking this issue of equity and diversity seriously, because it's no longer, it can no longer hold just to sort of, accept that things can go on as they are, because the healthcare system is more and more reliant on nurses of color and non-white nurses and so on. So it's something that they have to take seriously. I want to thank Dr. Flynn for a very interesting and provocative lecture. Thank you very much. And Peace Studies thanks you a lot to the Department of Black Studies and the Sinclair School of Nursing. Please be on the lookout for the other events that we have planned for this month. Mary sent out a link to the Peace Studies website, and there is also the Black History Month calendar that is on the Department of Black Studies' website. All right, at this point we have to bid you farewell.
Okay, just once, Dave, can I think one of the other members, I thought that she had raised her hand, of HPAR is also here. I think I saw Leslie. I can only see hands, raised hands. So could Leslie just speak quickly for a second? Leslie?
Leslie, where's Leslie? Okay.
Okay, there.
Leslie, you'll have to unmute.
Hello, can you hear me?
Yes.
Yes.
Yes, hello everyone. I'm Leslie, and I would like to start off by thanking Dr. Flynn for talking on our story with HPAR. It's such a great feeling to hear that we're being heard, and we're being recognized as part of a study. I can say that HPAR has been a great help for me. I am one of the members that have been employed at the hospital for the longest time, and always been fighting to have a leadership role. And I think with the development of this organization, HPAR, that it has allowed me to at least have a little leadership as being a nurse educator. And in the role so far, I see that there is a great need, that they need more Black women or Black people in leadership roles, because I leave my door open, and believe you me, most of the Black employees are at my door speaking to me about the issues that they're having, asking for advice on how to deal with this. And it's because they have that trust value in coming to me for their issues. There is a lot of work yet to do at Grand River Hospital in regards to having more leadership roles. There is still a lot of pushback. A lot of people, you'll see like the questioning in their faces when they do see me, because I have my office there and my name is there, and you'll see the double take. In some issues, there's people that know me and somehow they don't know me anymore. They don't even say hello to me in the hallway. So, I mean, I always have to hold my head up high, and I do have HPAR and the members that I have there to support me in my role. So.
Thank you very much, Leslie. Karen, just as a point of information, can you remind the audience what does HPAR translate to? The acronym.
Health Professionals Against Racism.
Health Professionals Against Racism. All right. All right. And this is a multi-racial organization. What's the composition?
Helen, what's the composition?
I think
No, they're just, well, from my understanding, they're all people of African and African.
Yeah.
Yes.
Yes.
African descent. Yes. Yeah.
Yes, we are Black individuals, African descent, and we all came together. It all started when the issue with George Floyd came about, and then of course with the COVID-19 effects and the Black nurses being highly affected in the sense of being assigned these patients, as well as seeing a lot of Black patients within the hospital not being treated well. So yes, it's healthcare professionals against racism. We also have reached out to other hospitals within the area that we live in to take part, because we noticed that it was affecting the region.
And I think something that Leslie, we can add is that our intention was to add everybody. We wanted allies in there. We wanted other immigrants, but it proved very hard because our courses were different. When we talk of certain things, there's discrediting. I remember talking to a doctor who is not Black but Indian, and he said, "Do you think that racism does exist?" So we are at different points, and the aim is as we grow, we will still add other chapters, and we were hoping to embrace everybody, and then we can continue this fight as a united front. Membership is open to anybody interested. We're looking for allies. We want to impact change, even in the States. Wherever we can go, we are willing to sit with you, talk with you. Our aim is, the most important thing is we need to take care of each other and our community members. So anybody is welcome, and we are an open door. We are open to any talk. When you come here, it's an unjudgmental zone. We sit down, we talk about experiences, and we validate those experiences, and we empower each other. And through just talking of how we can handle these issues from experience. We have a wealth of experience as HPAR members. So it's an open door group. Anybody is welcome to join us. And we're hoping to bring it to go further and even just make it very global.
All right, thank you very much. And on that note, we will have to bring this to a close. So thank you, everyone. Thank you, Karen, again, Dr. Nseba, Mary, and thank you to the audience for attending. And we will see you again soon. Good night to everyone.
Good night.